So my name is Sanjay Siddhartha. I'm a psychiatrist. I have been here for the last 29 years or so. I'm also the chief of staff for Miramichi Hospital. Bipolar 1 disorder is a serious mental illness. It involves two phases of the illness. One is called mania or hypomania, and the other one is depression. During mania, the person's mood state gets elevated. So either it's elated or irritable. The person would feel on the top of the world. Their judgment was impaired. There would be decreased need for sleep. So they are always on the go. Their thought process is rapid. You cannot interrupt them. So the person jumps from one topic to the other. They try to buy a lot of things. They become indiscreet in their personal relationships. And that is against their personality. So after a phase of mania, they would get eventually to their normal state, or they may get into a depressive phase. So in depression, as we know, they would get sad, they would have problems with sleep, there would be problems with weight loss, social withdrawal, lack of interest in surroundings, feelings of worthlessness, suicidal thoughts. So bipolar disorder comes in phases from mania to depression. In bipolar 1 disorder, it's frank manic illness, meaning the person has overactivity, grandiose thinking, impairment, significant impairment in your social, occupational, interpersonal, academic functioning. In bipolar 2 disorder, it's less intense form of manic illness. So the person may not be, so to say, in that way that they are out of control. They may still be something not quite right about them. They may be talking rapidly, but they would include, if you like, their illness somehow with their day-to-day functioning. And all that would manifest, but that is a subtle or, so to say, less intense form of mania, is hypomania. And then we call it bipolar 2. We are not sure about the exact causes, but the most popular theory is it's not the environment that would cause us to have a bipolar illness, it's our genes. We do not know what exactly causes it biochemically. There are several theories about that. It's the unstable cellular environment, that is what has been told to us, or some subtle dysfunction in some of our brain centers that may cause that. One traditional way, if you like, is that a family physician sees the person, or the primary care provider sees the patient, sends the referral to the psychiatrist. But short of it, and this has become quite user-friendly now, if I have a daughter or a son or a family member who needs immediate help, would get in touch with the community mental health clinic, and we can bypass the slow referral process. The person could be seen immediately if they are in an active illness phase. So our mobile crisis team or the flexible assertive community team can be involved from day one and make it happen that the referral is sent to the psychiatrist immediately. The main cornerstay of the treatment are the biological treatment. Some of the medicines would work the best for bipolar illness. So it's lithium, which prevents highs as in mania and lows in depression. Lithium also treats mania. Lithium does not treat your depression very well, but it prevents depression. Then there are other medicines which are being used, such as divalproex or valproic acid, which is known to help with manic symptoms or high symptoms, or to treat the aggression well. Then for depressive phases, we have several options. The ones which we use or which are approved are quetiapine or Seroquel, Latuda or Lurasidone, cariprazine or Vraylar, and lamotrigine or Lamictal. So those are the medicines or agents used for the low periods. In addition, these people need a lot of support. So they are supported ably by in New Brunswick by flexible assertive community team in cases where they're serious, where there is lack of support, the intense symptoms, impairment in your functioning. All those factors would decide us to take on people with the serious illnesses on flexible assertive community team. So they need help with housing, they need ongoing therapy, they need some help with their occupation and rehabilitation. So all that is inculcated in the treatment program. So anyone can call the community mental health clinic during the work day hours, or the mobile crisis unit, which works from 8 o'clock in the morning till 8 in the evening. And even after hours, there is a provincial line to go to. But certainly between those hours, anyone can call that number. Either I have a problem or my family members or a friend suffers with this, can you come and help? Mobile crisis team typically goes to the person if the person cannot come to the mental health clinic and assess the situation. They have access to the psychiatrist all the time. The clinician can go attend to the patient, typically a nurse or a social worker, and they can call us, one of the psychiatrists, that we have such and such person with such and such issue, such and such going on. Depending on the intensity and depending on what exactly the person needs, we may need to see the patient at the same time. So if the person is too ill and needs to be brought to the hospital, we would visit the place where the person is, examine it. I can put them under the Mental Health Act if they're not willing to come, or they're a risk to themselves, others, or of immediate deterioration in their mental health, and they can just be brought to the hospital when the time of the crisis to time of admission to time of stabilization and to rehabilitation is followed almost by one team, continuous one team, rather than disjointed care. The first thing is to get in touch with your primary care provider. If it's intense enough, go to the mobile crisis team, insist on a referral to a psychiatrist as soon as possible, get the diagnosis, start the treatment, work closely with the psychiatric team, your local mental health team, and then go from there.